Hello. Hi, everyone.
Thank you.
Welcome you all in this webinar, the monthly conjoint webinar of the African Commission and the EMR Commission of International League Against Epilepsy. We have today really two important lectures. The second lecture will be epilepsy with infectious comorbidities. The first one will be the post-traumatic epilepsy. The first one will be presented by Dr. Hassan Al-Shammari from Iraq. Dr. Hassan Al-Shammari is a consultant neurologist, assistant professor of neurology at Kurdistan Medical College. He got Iraqi Board of Neurology and Jordanian Board of Neurology and a diploma from UCL, United Kingdom. He is working now in Erbil in Iraq. The lecture of Dr. Hassan will be post-traumatic epilepsy. So please, Dr. Hassan, can you start your lecture?
Thank you, Professor Raif. I appreciate your kindness and choosing me today for having this lecture. Do sharing my screen quite clear?
Yes, very good.
I will stop the video. Good evening, everyone. I'm Dr. Hassan Shammari. I'm a consultant neurologist based at Erbil, north of Iraq. Today, I'm going to speak about post-traumatic epilepsy mechanism and prevention. So I may extend my thanks to Professor Raif for choosing me for this event today, and also for the International League Against Epilepsy office. So I will start with the presentation of this lecture. I would extend also my thanks to Shanks and Sharma and his colleagues for the very nice and comprehensive review article about the neurophysiological mechanisms and treatment strategies for post-traumatic epilepsy. That's published in 2021. And I do extract most of my lecture slides from this very interesting review article that describes all the facts that happen in patients with the post-traumatic epilepsy and in patients with traumatic brain injuries. So traumatic brain injury is a leading cause of death in young adults and a risk factor for acquired epilepsy. And severe TBI causes numerous neuropsychiatric and neurodegenerative problems with the varying comorbidities, and brain homeostasis may never be back to restored normal status. So of those affected by severe TBI, more than 50% they may develop post-traumatic epilepsy in the next years of their life. Well, so regarding the epidemiology of post-traumatic epilepsy and TBI, there are more than 3 million people in the US suffer a TBI each year. 80% are mild, 10% moderate, and about 10% they are quite severe, accounting for around 300,000 hospitalizations and around 50,000 fatalities annually. So the incidence is according to the age group. Most of the time, ages of children and young adults are the victims of traumatic brain injuries in different severities. 2% of the US populations live with long-lasting disabilities stemming from TBI. And the annual cost for TBI in the US is around $56.3 billion. Well, according to the American Academy of Neurology definition for severe TBI, it's defined as a condition in which a person stays in coma for longer than 24 hours, or he necessitates surgery to save his life or save his condition, in fact. And most of these surgeries directed to reduce intracranial pressure or removing intracranial hematoma, whether it's subdural or intracerebral. Seizures may be immediate, that happens in the first 24 hours, or can be as early as in the first 7 days. And I would emphasize that in the next few slides, I'll show that some of those patients, they will continue to have subclinical seizures or non-convulsive seizures throughout their first 7 days while they are in intensive care units. And epilepsy may happen in the next 6 months, which is the late type of epilepsy seen in patients with TBI, or even may happen more than that in the next few years of their life. Nearly 40% within 6 months of injury, they may develop epilepsy, and 50–60% within the first year, and around 80% of those patients with severe TBI, they may develop epilepsy in their later years of life. So it's quite common to be seen in patients with TBI, and especially the severe one. Traumatic brain injury is the third most common cause of all epilepsies, in fact, in all patients with epilepsies. And this pie chart shows that the different types of traumatic brain injuries encountered in the intensive care units and in the ER. So around 28% of those patients, they have falls, 20% they may have RTAs, or struck, and 19% they may struck by, against, and 11% assaults, and so on. Well, this is a CT scan of a patient with a moderate to severe head injury, and you can see that there is a fracture in the base of the skull with extradural hematoma pressing on the nearby temporal lobe with extensive damage involving the soft tissues around the head and in the of the orbit. Another example, this is an MRI of a patient with the contusion to the frontal lobes bilaterally. And you would expect that those patients, they end up with a lot of psychiatric presentation in form of aggression and sometimes apathy and mental changes, in addition to the post-traumatic epilepsy. Well, classification of TBI morphology, you can see that TBI, or the brain damage, can happen due to different kind of movements that happen with the trauma or with the RTA or whatever. That's acceleration, deceleration injury, lateral movements, or rotational movements. And if the patient hits his head with the solid structure, you may have both direct trauma to the brain causing direct insult or contusion in the brain, in addition to the axonal shearing process that may happen also on those patients. Well, for whom we may have more risks of having PTE or post-traumatic epilepsy, those patients absolutely with the more severity of head injury, they have the more incidence of having epilepsy. Patients older than 70 years of age, 60 years of age, they have more incidence of epilepsy. And those with the brain contusion, while intracerebral trauma, you may know that it may cause epilepsy if it is a spontaneous one, like in stroke patients due to intracerebral bleeding, or due to hematoma due to brain injury. Both of them, they would cause epilepsy in most patients. If a patient had developed his early seizure in the first week of trauma, he is more liable to have PTE later in life. Well, I'm going to describe a little bit in details. I'm trying to concise the epileptogenesis, how it happened, and the pathogenesis of trauma and what happens to the brain and how epilepsy happens in those patients. Focal injuries usually cause contusion, as you may know, hemorrhage, infarction, and necrosis in the brain tissues. And this subsequently would lead to cortical scarring due to the effect of astroglial cells. And this again would lead to synaptic plasticity changes and sometimes recovery. Sometimes this synaptic plasticity would end up with the PTE. Diffuse injury leads to axonal shearing, microvascular damage, the release of inflammatory mediators, and free radical overload. And I'll show you in the next slides how diffuse injury would cause more damage than the localized one. Later, a secondary injury mechanism recognized the neural circuits and disrupt brain homeostasis. And I will show you also how these neural circuits in the brain will be changed in the patient with TBI, leading to more epileptogenesis, with a degree of secondary damage largely depending on the severity again of the primary damage. And as much as the primary damage is severe, we will end up with more secondary damage. One of the most important factors in epileptogenesis in patients with the TBI is the release of glutamate, which is the most toxic neurotransmitter into the intracellular compartment, in the extracellular compartment, and this would lead to the release of calcium, excessive calcium in the extracellular compartment, and then when calcium passes to inside cell, it would cause a kind of, it would withdraw water inside the cells and would end up with the swelling of the cell and cell death, and subsequently due to edema. So furthermore, the recruitment of glial cells and peripheral immune system, such as leukocytes and macrophages that happened due to this damage, would aggravate the neuroinflammatory process, and there are more cytokines will be secreted in the region of the insult. These combined mechanisms of primary and secondary insults commence a vicious circle of a neurodegenerative process that persists for months to years. So a patient with TBI, he won't, when he recovered the first event, he won't end up with that. I mean, there will be a progressive process that happens inside their brain, leading to more permanent damage and changes in their brain circuities and, let's say, different regions in the brain. There is the part that related to the blood-brain barrier and disruption of the blood-brain barrier in patients with the TBI, especially the severe one. This will lead to that blood cell chemotaxic and their transmission into the brain. So the blood cells will start to migrate inside the brain, leading to more damage. Enhanced leukocyte infiltration and invasion of the CNS parenchyma generate a cytokine storm, which induces more neural damage and subsequent brain edema. The blood-brain barrier disruption after TBI causes dysfunction in the pericyte endothelial interaction and increases in toxic accumulation of serum-derived proteins in the brain. So all these processes, again, the chemical ones and the due to the disruption of the blood-brain barrier and others due to glutamate, would end up with the complex damage to the neurons and more complex damage to the brain and the formation of epileptogenesis. Well, there is a role of mitochondria. It's very well known and understood that mitochondrial dysfunction has long been recognized as a key source of oxidative stress in epilepsy. So when there's destruction to the mitochondria and mitochondrial wall, we would end up also again with the release of many substances and free radicals. And again, this would increase more the inflammatory process inside the brain matrix, and we will have more epileptogenesis. Well, the physiological and structural evidence of dendritic loss, this is what usually seen in the hippocampus region, and modulation of dendritic spines density and hippocampal sclerosis have widely been associated with increased seizure susceptibility after TBI. And I believe that this kind of changes that happen in the hippocampus is a kind of reaction to what happens inside the brain, whether it is a focal brain injury or a shearing injury and axonal injury. And these kind of reactions inside the brain mostly is one of the most common causes of epileptogenesis and having epilepsy in the future. There are numerous reports on the unilateral or bilateral loss of neurons in the hilus and CA3 region of the hippocampus, progressive mosaic fibers sprouting in the inner molecular layer of dentate gyrus, and hyperexcitability in the dentate gyrus circuitry several weeks after TBI. So this is again one of the reasons that would increase the possibility and liability to have a post-traumatic epilepsy. And this is the normal circuits usually observed in a normal brain in the patient's normal person. You can see the dentate gyrus and the CA3 and CA3 region and CA1. And especially dentate gyrus changes and CA3 would lead to more hippocampal sclerosis, and we end up with the temporal lobe focus of epilepsy. Well, what types of seizure usually you observe in patients with PTE? Most commonly, we may expect it should be a focal seizure, and the most common one is the complex partial one or simple partial one, while secondary generalization, that's what makes the epilepsy resistant to treatment. Psychogenic non-epileptic events also have been observed in around 30% of patients with TBI. What other symptoms that usually encounter in patients with TBI in practice? And it's quite true because I'm seeing a lot of patients with TBI, and I'm seeing what was going on with them in the next 3 or 6 months or 1 year in their life. Many of them, they develop post-traumatic stress disorder. They may have anxiety disorder. They have personality changes. They get aggressive and hardly to be calmed. They have sleep changes, and they have chronic pains, just like migraine and fibromyalgia. They have absolutely cognitive changes. They cannot go back to school if they are young children or young adults, and they will suffer from that again. And there may have also motor, like hemiplegic change, or sensory impairment, and they may have this endocrine dysfunction and GI disturbances. I've got patients, they have Parkinsonism also. They may have movement disorder like rubral tremor due to the injury of red nucleus in the midbrain. That's responded lately and partially in one patient to the Vitrastam. Chorioathetosis and dystonia also, I did see have some patients with post-traumatic injury, they may have these movement disorders. The long-term consequences expected of patients with TBI and PTE. If the patient have a closed head TBI, causes bleeding or intracerebral hematoma, which raises the risk of lasting impact on the brain. Moderate to severe TBI may lead to dementia in around in the next 30 years of life follow-up. And over 40% of the troops that suffer TBI develop PTE in their lifetime, with lasting effects including confusion, cognitive deficit, depression, and anxiety disorders. Well, long-term follow-up studies on veterans also revealed that about 18% of veterans experienced their first seizure after 15 years of their injury. Most had seizure after 1 to 5 years, and about 2/3 are on lifelong medications, AEDs. Interestingly, having a family history is one of the causes that the patient here is more liable for PTE. If the patient had a traumatic brain injury and he had a family history or genetic causes for epilepsy, they will have more liability to have PTE than other people. Video EEG monitoring and MRI studies most of the time shows that the changes that happen in the hippocampus, or there is a mesial temporal lobe sclerosis in most of those patients, in around about 30% of those patients. Well, vast majority of cases develop focal epilepsy, as I mentioned, due to hippocampal sclerosis or damaged white matter fibers connecting to the hippocampus. Continuous EEG and PET scanning in 16 TBI patients revealed that 28% of them, they have non-convulsive seizures where they are in the intensive care unit in the first 7 days of injury. Repeated TBI, or continuous or repeated TBI, can alter neural circuits and lead to a long-term degenerative changes in the brain, as we mentioned, and mostly it's the cognitive one. Sorry. Excuse me. Well, in the periphery, again, in the outside the brain, the extracranial parts, let's say in the body, we may expect cardiac complications of PTE in form of increasing morbidity and mortality due to enhanced cardiac contractility and arrhythmias. And we may expect patients who may have high blood pressures and production of myocardial free radicals. Well, as we said, the most toxic substance or neurotransmitter that's released in the patients with TBI is glutamate. So using glutamate antagonists, it can be one of the factors that may reduce the damage caused by this neurotransmitter. So ketamine, glutamic acid, dopamine, dextrose aspartic acid, dextroaspartic acid, and methyldianolone. All these agents, if it's used early in patients with the TBI, it may reduce glutamate toxicity. Well, regarding therapeutic interventions and management in patients with TBI, In fact, currently, there is no therapies are available for permanently treating TBI-related injuries. In one interesting study, there is significant outcome was observed with the NeuroAid or MLC 901. It's a herbal Chinese traditional medicine present in some countries all over the world, not everywhere, in fact. It's present here in our country, and I'm using it for TBI patients, in fact, with a really good outcome. And it's now under the evaluation of the FDA, and it passes the stage 1 safety process, and it's now in stage 2. And this material, in fact, or drug, it has 9 compounds, and now the FDA approved 4 of them to be, let's say, a precursor for nerve growth factor, or enhancing nerve growth factor and vascular growth factor. But still it's under trial, and still it's under study. Post-traumatic epilepsy, 1/3 of epilepsy patients are refractory to anti-epileptic medications. And the pharmacological inhibitors of free radicals, such as nitrous oxide, peroxidase, prostanoids, antagonists, can modulate free radical production and suppress inflammation. There is the role of intracerebroventricular infusion of interferon AR significantly improves cognitive deficits and motor function, but still is under study. And it upregulates neuroprotective agents and reduces lesion volume. Designing strategies that target aberrant neurogenesis and synaptogenesis. What I mean by that, you know, whenever a patient is exposed to a central nervous system injury or peripheral nervous system injury, there will be a process of plasticity that happens in the brain and the peripheral nervous system. This kind of plasticity is a kind of a blessing. I mean, many of the functions may be recovered because of this plasticity that happened in our brain. And this plasticity is responsible for new neurogenesis and synaptogenesis. But this process, if it happens inside the hippocampus, it would be unwanted, because this would lead to epileptogenesis in those patients with TBI. So if we can design a strategy that improves neurogenesis and synaptogenesis in different parts of the brain, but not, stopping them in the hippocampus, that would improve the outcome and prevent more epileptogenesis in patients with TBI. Well, controlling brain swelling and preventing hypoxia or ischemia is very important. Lowering intracranial pressure by medical or surgical treatment like ventricular drain or decompressive craniectomies, all of them, they would reduce more brain damage and more destruction that happens in those patients. Medical management that include different kind of management, including maintaining body temperature, maintaining blood sugar, maintaining blood pressure, and monitoring oxygen and carbon dioxide, preventing hyponatremia, decreasing cerebral metabolic demand, and improving cerebral perfusion pressure. All these kind of medical management, they would improve outcome in those patients and preventing more epileptogenesis and more destruction to the brain. Well, the prophylactic use of anti-epileptic drugs that being used for patients with TBI, it may reduce the occurrence of seizure at that time, but it will not, let's say, prevent PTE from happening. So if you are using Phenytoin or you are using levetiracetam, as I will mention later, this would reduce the severity of our having epilepsy at the moment of impact or in the first few days, but it would not change the progress to PTE. So this is what people should know about that or neurologists and epileptologists, that these anti-seizure drugs, they will not stop having PTE in the future. The surgical intervention is not generally recommended in those patients with PTE because that a seizure foci can be difficult to localize. We cannot localize exactly where is the LQS area in the brain to be removed. And that's due to technical issues, such as a craniotomy and the breach rhythm, which I will show you now. This is the breach rhythm that observed in patients with a craniotomy, and it's just like an epileptic discharge. So you cannot know whether this is a real epileptic focus or not. Well, patients with severe TBI may have diffuse cerebral or axonal injury evident on EEG recording as multiple epileptic foci, so which to remove, in fact. So patients with diffuse axonal injury, they may have multiple epileptic foci and hard to choose which one of them. That's why VNS may be a good, let's say, suggestion for those patients with resistant epilepsy, because VNS is a kind of generalized inhibitor for epileptic discharge. Well, again, phenytoin during the acute phase may lower the incidence of epileptic discharge and epilepsy from 14.2 to 3.6. Levetiracetam is less toxic nowadays and more popular to be used in practice, while carbamazepine and sodium valproate are the preferred long-term treatment for PTE. I myself, I would choose carbamazepine because most of the time these are focal epilepsies, or a drug that's derivative of carbamazepine like oxcarb or esticarbazepine. So, concluding remarks. Let's finish up with this issue that's anxiety toxicity, neuroinflammation, oxidative stress, and neurodegeneration are the primary pathognomonic mechanisms. And the primary source of cellular toxicity is the elevation of glutamate again. The initial immune response, if it is well controlled, it would be beneficial to prevent more injury. Impairment of mitochondria would lead to more deleterious effect and more having epileptogenesis. Pro-inflammatory cytokines and chemokines are the key players in released by invading blood cells like microglia and astrocytes and neurons. The invading cells that release cytokines would affect the neurons and astrocytes. Invasion by leukocytes and activated microglia leads to tissue damage at later stages. Both focal and diffuse mechanisms can result in PTE, and approximately 20–30% of PTE cases are associated with the reactive mesial temporal sclerosis, either by direct injury or it's a reaction to the what happens in the brain. AEDs remain the first line of treatment, yet AEDs are not very effective in preventing PTE. Patients receiving AEDs often require lifelong treatment. Early phases of epileptogenesis should be targeted before the imbalance spreads to other regions of the brain. Ultimately, a clearer understanding of the molecular mechanism of epilepsy will allow development of truly novel therapeutic targets for PTE. And thank you. The floor is yours, Dr. Hai.
Thank you, Dr. Hassan, for this nice presentation. You concentrate on the pathogenesis and epileptogenesis, which is a very important, really, part of the story. Well, we are now waiting for any questions from the audience. Just waiting for their questions. I just want to ask you, Dr. Hassan.
Yeah.
There is, you mentioned in one of your slides that there, sometimes after 10 years or 15 years, you may get post-traumatic epilepsy for the first time. Well, my question is, there is a relation between the length of appearance of post-traumatic epilepsy and the severity of this.
Well, I'm sure you are also encountered in your practice that a woman bring her child that he had epilepsy, and for the first time, for example, and she's mentioning that this child had already all the trauma. He fell from height, or he had an RTA before, and let's say possibly before 5 years, before 10 years. And in fact, having such a long time, it won't say whether the patient he may have a resistant epilepsy or not, in fact, in practice. And it's not mentioned here in this review article whether those patients, if passing many years and then they have their first seizures to happen, whether those patients, they will have more severe kind of PTE than other people. But still, I believe in my practice that those patients that are highly responsive to anti-epileptic medications and they get easier with the, and you can treat their epilepsy easier, especially with the treatment that, let's say, targeting focal epilepsy most of the time. And they absolutely need imaging to find out where is the focus. Sometimes you can see a scar tissue in their brain and the cortex on the subcortical areas.
You know, we in Iraq, you know, we are really very rich in the post-traumatic epilepsies because of the long-standing wars and before the 1980 and later on. And we usually found patients or wounded people, soldiers, after 10 years or 20 years, developing the epilepsy for the first time. And I think it is said that the more late the seizures will appear, the more severe those seizures will be. My other question, can I propose that after one single seizure late, you know, have two types of seizures in post-traumatic. We have the immediate or early within 1 week, which are seizures and are not regarded as epilepsy because they are, you know, provoked ones.
Yeah.
After 1 week, they are usually regarded as unprovoked. So they may share or start the process of epileptogenesis. Well, can I assume after one single post-traumatic seizure late that I got epilepsy?
Yeah.
Say after.
If there's an EEG evident. If there's an EEG evident, and you need to start treatment. It is first.
Yeah, you are right. EEG may be very useful in diagnosing this, but you know the recurrence. You know the definition of epilepsy in the recent time to have two seizure recurrent in more than 24 hours apart.
Yeah.
Both are unprovoked, or to have one seizure with a recurrence of 60%. Possibility. And in the post-traumatic late epilepsy, they found that the recurrence rate is 80%. So you can, I think, you go. But you know, as you say, the EEG is very important. And this, although EEG, the yield of EEG in post-traumatic epilepsy is not very good, but when you find abnormalities in the EEG, it will give you a good clue for the severity. Yes. When we go to other two questions from the audience, are there any predictors for post-traumatic epilepsy? In one of the questions in my front of mine.
It is the severity. Most of the time, it's the severity is the predictor of having PTE, and it's very clear from. It has been mentioned that around 50% with the severe traumatic brain injury, according to the American Academy definition of severe traumatic injury, they will have 50% possibility of having PTE in the future. So it's the severity is the key most of the time that having epilepsy in the future.
All right. Well, another question I think you have answered it during the lecture. Is there any personal or clinical evidence of whether early use of anti-inflammatory drugs like corticosteroids can decrease incidence of post-traumatic epilepsy?
Well, regarding steroids, it's not even used in traumatic brain injury because the type of edema expected, it is most of the time, it's a cytotoxic edema. And I have explained that patients with the traumatic brain injury, they have glutamate release and calcium influx and water accumulated inside the cell and edema. And this kind of edema is just like a stroke edema, where steroids are quite useless. But in my practice, when I see patients with the, let's say, subdural hematoma, it's a mass-like lesion that, say, presses the brain, I would believe with subdural hematoma, dexamethasone or steroid would be helpful to reduce the, let's say, the mass edema or the space occupying lesion edema. But for the original pathology that causes epileptogenicity in patients with traumatic brain injury, steroids are doubtful and not even mentioned in this quite comprehensive review article, because the type of edema, this type of edema is not responsive to steroid. It's not like the interstitial edema that's caused by hydrocephalus, or the brain or vasogenic edema that's caused by brain tumors. This is different kind of edema. That's why it's not responsive to steroid.
Well, thank you. Very good. Another question, which will, for how long drug prophylactic after TBI continue? Well, this will, open another question for you, that is the prophylaxis acceptable or not?
Well, he meant the prophylaxis or the
prophylaxis.
I mean,
Drug prophylaxis.
It has been mentioned only in the first 1 week. Just the first 1 week. I mean, you are using phenytoin or levetiracetam injectables only first 1 week, and then you observe if the patient develop PTE or not.
This is your personal practice, you mean?
Yeah. This is what we usually use in practice, and just 1 week, for 1 week.
There is a wrong practice, as you know, going on. That is the prophylaxis. It is always said in literature that prophylaxis will never prevent post-traumatic epilepsy. You may prevent post-traumatic seizures in 1 week, and your treatment and your early treatment will be very useful and very good to prevent post-traumatic seizures. Post-traumatic epilepsy will be not prevented by prophylaxis, and they really the literature and that prophylaxis is not acceptable. But our practice, at least in Iraq, we usually you are using
we encounter
after surgery.
Some of our colleagues practice that they use prophylaxis for 6 months, as I usually notice with many people. I mean, even for patients with moderate TBI.
I think it is a personal decision. But literature, I mean, evidence-based is not accepted to give prophylaxis because it will not prevent the prophylactic, the post-traumatic epilepsy, although may be very useful for post-traumatic seizures in the first week of. I don't know whether any other questions from the audience. Well, I think that is enough. Well, thank you very much, Dr. Hassan. It's a very good really lecture, and you concentrate on the very important part, which is the most difficult part, that is the pathogenesis. Thank you very much.
Thank you. Thank you.
Well, we now shift to the second lecture in our webinar, that is epilepsy with infectious comorbidities. This lecture will be presented by Professor Richard Edro from Uganda. Dr. Edro is the immediate past president of Uganda Medical Association, a senior lecturer at Makerere University School of Medicine, and consultant pediatrician and pediatric neurologist in Malago Hospital. Well, he leads a pediatric neuroscience group in Uganda. His research usually focusing on parasitic infections and interventions to improve the outcomes in children. He got more than awardee, or 2 or 3 or more. He sits now on boards of Global Health of Uganda, International League Against Epilepsy, and International Child Neurology Association. So, Dr. Richard Edro, please, to start your lecture.
Thank you very much for the kind introduction, and I would like to thank the League for inviting me to share my thoughts about some of the work which we are doing. And most of my work is in infections and its association with epilepsy. So I do not have any particular disclosures to make with during this presentation. A few years ago, there was a publication of a large study which was conducted in 5 African countries, in Eastern Africa, in South Africa, and in West Africa. And this study looked at people with epilepsy and divided them into 2 groups: children under the age of 18 years and adults 18 years or older. And the most important risk factors which came out from this study, and especially for those in the older ages, teenage years and adults, were a history of admission with malaria during childhood, then exposure to several parasitic infections, including Tinea solium, Tinea canis, Toxoplasma gondii, Onchocerca volvulus, a history of NCDs, hypertension. But what was clear was that parasitic central nervous system infections were one of the most important causes of acquired epilepsy in these areas of sub-Saharan region. So for purposes of this talk, I'm looking at a range of infectious diseases which are associated with epilepsy or have epilepsy as common sequelae. And this may be some of the acute infections, and the acute infections, I've put them into 3: cerebral malaria, acute bacterial meningitis, and the different viral encephalitis. Now, these 3 acute infections which acutely produce coma all have mortality ranges during the acute episode lasting between 15 and 30%. But between a quarter and up to 40% of survivors actually have neurocognitive deficits. And one of the neurological disorders as a consequence, as a sequelae in over 10% of these patients is epilepsy. The next is the range of multiple brain infections other than malaria, the parasitic infections, some of which are just mentioned from the large study, which was led by Professor Charles Newton, as I said, in Uganda, Kenya, in Tanzania, in South Africa, and then in West Africa, in Ghana, in the Kitampo DSS area. Of course, we have several other infections, consequence as of neonatal infections. We have a lot of TB in Africa, and then there's the problem of HIV. HIV directly from the virus itself, but also the opportunistic infections which follow HIV disease. I just wanted to demonstrate, especially in the sub-Saharan African part of it, that 3 common causes of acute non-traumatic coma in East and Western Africa, and even the upper parts of Southern Africa are always quite similar. Here I have records from wards, from a ward in Uganda where I've been working, and then another ward in Nigeria, in southeastern Nigeria, and during similar periods. And what is clear is that the leading causes of acute coma and acute seizure disorders, many of which then progress to epilepsy, includes the cerebral malaria, as I mentioned, acute bacterial meningitis, and often because of diagnostic difficulties, because we do not have PCR deployed in many of our hospitals. The viral encephalitis, people hardly know what the cause is. After they have done a blood slide, it is negative for malaria. They have done the CSF, and there is no bacterial meningitis. Often you get stuck as to what the diagnosis, and many of these are due to viral infections. And the etiology is really similar for these 2 areas. But this is opposed to in the Mediterranean area, for example, in Egypt. This is another and from another ward of about 100 children, where you can clearly see that metabolic disorders and cardiovascular infections and toxic mediated diseases are a larger cause of acute coma as opposed to infections. So regionally, the etiology varies from where one is. But focusing on malaria, because this is potentially one of the biggest causes of acquired epilepsy in beyond childhood. Now, things are improving, if I can start with the good part of it. But because of the high transmission in the different areas, as you can see in this figure, which was in the figure of the year 2000, that time there were about worldwide a population at risk of malaria was about 2 billion. But in any one population, you have people who are infected, but they carry the parasitemia, they are asymptomatic. They have developed a level of immunity which is protective to them. Now, some of those who have partial immunity, especially school-age children and then the younger children, may develop uncomplicated malaria. But of 1% of these who develop uncomplicated malaria can progress to severe malaria. And this includes diseases like cerebral malaria, where you invade the brain. But because of the massive deployment of malaria control measures, things have markedly improved. And in fact, the malaria morbidity has now declined from about 500 million cases down to about 200 million cases a year. Cerebral malaria itself is the most severe neurological complication. It is characterized by an arousable coma, but it's a diagnosis of exclusion, which means that there should be asexual forms of Plasmodium falciparum on the blood film and no other cause to explain what the cause is. Mortality, as I mentioned, is in the range of 10 to 20% despite the best available treatment. There's a 10% chance of death, despite everything which you may do. But this mortality is lower when the artemisinin compounds are given compared to quinine. But of those who recover, of the 90% to 75% of the people who recover from cerebral malaria, 25% or a quarter of them have long-term neurodisability. And epilepsy actually develops in about 10% of these patients. Now, diseases like epilepsy tend to develop about two years to up to 6 years after the exposure. They do not develop immediately. The underlying pathophysiology is the sequestration of infected red blood cells in the cerebral vessels. Here, this is a retinal vessel where you see, if I can get a pointer, yes, where you see a lot of red blood cells along the blood vessels, and so much so that impairing circulation in this area. And if you may see the same happening here, because of these blockages, the distances in the next place, you see these pale areas, is because of impaired perfusion in this. So this is from an indirect retinoscopy in a study which was done in Malawi. So a number of different agents, host proteins are involved, and through which the malaria-infected red blood cells expresses antigens on its surface on the histidine-rich proteins, and using these knobs, it then attaches to the lining of the endothelium. And so this cytoadherence of the parasites mediates this. But even the infected red blood cells attract more infected and uninfected red blood cells and form rosettes, and or they may use platelets and agglutinate, and so much so that you have areas of impaired perfusion. Again, this is looking in the eye of, this time it is a 3-year-old, and using fluoroscopy, retinal fluoroscopy with the fluoroscope imaging injected in the eye, you have areas of defects. And this over 1 to 3 days, may improve with perfusion, with treatment. The challenge is it can improve very
Possibly there is a problem in the net surfaces, I think, in Uganda, waiting for Professor Edro to complete his lecture. Still waiting for Dr. Edro. Oh, he will hopefully can rejoin. Really, even the lecture of Dr. Hassan was again in the comorbidity pattern, because you know, epilepsy here itself is a comorbidity of the brain, traumatic brain injury, isn't it, Dr. Hassan?
Yeah.
It is itself a comorbidity here.
It is.
Yeah.
In fact, I restored my internet access or connection today. You know, yesterday we do have storms and rainfalls, and we lost some connection with internet. But good thing that we do have it today in our home. So I didn't went to my clinic.
Very good. Can give us a short clue about treatment in the meantime when we are waiting for Dr.
Well, you
Edro?
know, I come across many patients with traumatic brain injury. In fact, I visit them many times at hospitals, and they visit me at my clinic frequently. Most of the severe types, they end up with the motor or sensory damage, and really they end up with cognitive changes. Many of them, their families, they complain from.
Well, he's coming, I think. Yes, he is coming.
Yeah, so they complain from their cognitive changes, their aggressive aggression.
Okay. Thank you, Dr. Thank you.
My apologies. We lost connection from where.
Yeah, no problem.
Yes. So quite a number of these children develop this such severe brain swelling. In some of them, this can progress to intractable raised intracranial pressure and herniation, and you have children dying from herniation. Some of them resolve, or others resolve, but the children end up with severe brain injury, and many of these children are spastic. They have severe epilepsies along the years with severe injuries. So in the long-term outcomes, it has now been demonstrated that at least 1/10 of these children have epilepsy developing along the way, usually 2 to 6 years later, but some of them also develop neurobehavioral disorders. And this infection is really one of the leading causes of neurodisability and neurological disorders on the continent. A number of risk factors for this include, during the acute episode, having repeated and prolonged seizures, as demonstrated in the previous imaging, the intracranial hypertension, those who have had a deep and prolonged coma, and of course, severe metabolic derangements, especially associated with intractable hypoglycemia. Now, on the other hand, the other leading acute cause of acute coma, of course, especially in the younger children, is the acute bacterial meningitis. The good news is that since the 2000s, there has been a marked decline in the incidence of acute bacterial meningitis. Across the continent, the leading infectious agents, the leading bacterial causes include Streptococcus pneumoniae, Haemophilus influenza, meningococcus, and especially in those who are immune compromised, the non-typhi salmonella. Now, with the introduction of HIP vaccines across the continent, and then more recently with the introduction of the pneumococcal vaccines, there has been a more than 50% decline in the incidence of bacterial meningitis, and in fact, in some of the regions, over 90% decline. And so much so that if we continue with these interventions with meningitis, with time, the bacterial meningitis will no longer be an important cause of epidemiologically in terms of burden of epilepsy across the region. So otherwise, across, especially in the different African regions, you can see the density of these areas, that the leading causes of these three, H influenza, pneumococcus, and then meningococcus, and then of course the fourth being the non-typhi salmonella, they cause hundreds of thousands of disease, of meningitis, pneumonia, and other serious infections, and the sequelae of which is one of the sequelae of which is epilepsy. But because of some of the challenges which we have on the continent, some of the interventions which are carried out and easily given to try to reduce the incidence of neurodisability, for example, hearing impairment after epilepsy, some of them have not been as efficient. Here, there was a large clinical trial conducted in Malawi, in which children with a diagnosis of meningitis were randomized to either receive dexamethasone or placebo, because this is standard of care in some of the regions. But this study was conducted in an area with a very high burden of HIV, and the results were unexpected. Indeed, actually, giving dexamethasone tended to produce more harm than benefit, especially with GI bleeds and so overall in some of these areas, especially in HIV-infected children who are the most at risk of some of these interventions, some of the interventions which are known to be applied in other regions do not necessarily work in some of our areas. But the good news continues that in many areas, H influenza, strep pneumonia, the burden is declining, and we hope if more and more widespread use of vaccination, we should be able to literally eliminate or make these diseases no longer a public health intervention. But with the declining burden of malaria and the meningitis, the proportional burden of the unknown encephalitis or encephalopathies is emerging. And this probably includes many of the viral illnesses that now we are unmasking a number of some encephalitis which could have been due to the different viral illnesses. Indeed, viral illnesses remain the leading neuroinfections now in the region, and they're emerging to become actually the main CNS infection. And they may be in the years to come the leading acquired cause of epilepsy outside of birth asphyxia and outside of cardiovascular events. And many of the main infections include herpes simplex, human herpes virus, the Japanese encephalitis virus, chikungunya, and the West Nile virus. Because of limitations of diagnostic abilities, often it is difficult to establish, and then not many of them have treatments outside of cyclovir and ganciclovir. And so in many centers, no treatment is offered, and the children literally pull out on their own. We recently conducted a large survey in the initial pilot study involved patients from West, East, and Southern Africa, and we looked at a range of studying panels looking at different studies. And in each of the different regions, this included Ghana, Rwanda, Uganda, and Malawi. Many of the viral infections are actually the herpes group of virus, but it also includes others like varicella, CMV, and the human herpes virus group of viruses being responsible for the acute infections. But using more detailed studies to try to look at the CSF samples which test negative, we use next generation sequencing and using the omics, metabolomics, proteomics, and genomics, we're able to identify additional viruses. And again, many of these in the herpes group of viruses. And when you look at children who are admitted and who have multiple convulsions during the acute stage, actually many of them have, from this study, we demonstrated that actually many of them have this range of viruses, and some of them have co-infections. So that is the group of infectious agents in whom epilepsy becomes a consequence of the acute infection. But there are a group of infectious agents who may present with epilepsy, and such presentation with epilepsy may lead to the diagnosis of the disease. So they present as epilepsy as either a comorbidity or a manifestation of the presence of disease. And a number of health myth infections or parasites are associated with such disease. And this include Tinea solium or the notorious pock tapeworm, but also different other tinea, and including Echinococcus, the dog tapeworm. There are also a number of nematodes which are associated, and some of which I'll discuss in this presentation. And then the trematodes, schistosoma, especially which is along the freshwater lakes and the freshwater rivers. The Nile is very notorious for this. In the upper Niles, say Uganda, South Sudan, and going to Sudan, you have Schistosoma mansoni, but as you go towards Egypt, you get more Schistosoma hematobium. Schistosoma japonicum is not a main problem in our areas. Now, again, these large studies of Africa, which looked at active convulsive epilepsy, examined evidence for these parasitic infections. And 4 main parasites really emerged in addition to Neurocystic Psychosis. So one of them was Onchocerca volvulus, Tinea canis, Toxoplasma gondii, and of course, Plasmodium falciparum. Now, Many of these diseases, especially Onchocerca volvulus, which we'll deal with in more detail, and Toxo Caracanes, outside of the usual diagnostic tests which we usually carry, especially in the older patients, the teenagers and the adolescents and the adults who present with an initial diagnosis of epilepsy. Many of them usually do not have such diagnostic tests, and so the etiological agent is mixed. Let's start with neurocystic psychosis. It is now thought that this is the leading cause of acquired epilepsy across the world. 20 million cases of the 50 to 80 million people with epilepsy. In the 20 million cases, their epilepsy is a result of neurocystic psychosis. This disease is endemic in many parts of Asia, in Latin America, and of course in Africa. And it is the most common cause of acquired epilepsy in many of our developing world. It's often acquired from inadequately cooked meat, and when this is ingested, and they then migrate and disseminate in the different parts of the body, in the muscles and in the heart. Some of them end up in the brain, and it is this focal epilepsy which may be seen in the brain that is responsible for this. Here we have different images. In the initial stages, you may have cysts, and these cysts may calcify, and around the cysts you may develop edema and with the brain swelling, and those are fairly dangerous. Because of the surrounding edema causing raised intracranial pressure, those may require surgical interventions, especially because because they may cause an acute hydrocephalus. But in some, you may have multiple. Get a tight point again. You may have multiple areas with multiple calcifications, and the calcified lesions may be distributed widely. And if some of them may remain quiet, one may not even know, but some may be quite frankly epileptogenic. Diagnosis usually is on imaging, but one may also use enzyme-linked immuno and electrotransfer and blood assays for diagnosis. So the treatment is individualized. Seeing calcified lesions in the brain with no symptoms, one may not need any specific treatment. But where there is edema, prednisolone, dexamethasone may be important, and if there is raised ICP, surgical excision of this may be important. And in cases where there is active edema, it may be prudent that you may give steroids to try to shrink this before starting the antiparasitic drugs. Otherwise, you may degenerate the cyst, and then it may acutely spread, and the patient may fare very poorly. Of course, the seizures management of the seizures is as a symptomatic seizure. So the different drugs for focal epilepsy may be what may be indicated. In many of our regions, carbamazepine is widely spread. People may use it as appropriate. The other one is Toxoplasma gondii. This is a parasite, and about a third of the world population is actually chronically infected. But this agent often acts in the majority of people, it is asymptomatic. Most infections are asymptomatic, but they may, in some, you may have acute symptomatic seizures, and especially in the presence of immune suppression and with HIV. And many of these patients then present with focal deficits. They may have hemiparesis, hemiplegia, and really focal neurological signs. So serological diagnosis, imaging are usually the diagnostic tools, but Also examining the eye or use on fundoscopy, one may see chorioretinitis, not so distinct from that from the CMV. Now, for Toxocaractis, these are the dog and cat tapeworms. So Toxocaracanes for dogs, and then Toxocaractis. Human beings are usually incidental hosts in regions where people take dogs to parks. Their feces may contaminate vegetables, and especially if vegetables are then eaten raw, if they're not well washed, one may acquire this disease. And it is therefore common in children, especially when children may acquire it from playgrounds where dogs go and then they defecate and they contaminate, and then children get it. And otherwise, we are incidental hosts due to hand-to-mouth consumption of either raw vegetables or playing and contact with the feces of dogs and cats in these different regions. But toxocariasis also may present with other things. You may have larva migrants, or they may migrate in the eyes, and CNS infection is usually a rare thing. And again, antiparasitic agents using either albendazole or mebendazole, or one may use photocoagulation on the lesions. But where there is acute disease, again with swelling, one may need to use either dexamethasone or prednisolone to try to shrink it before you give this active disease and anti-seizure treatment. And often with the treatment of the agent, after some months, one may be able to withdraw the anti-epileptic drug. What is now emerging, especially in the equatorial region, is a very strong link between another nematode, Onchocerca volvulus, and epilepsy. Now, this disease is along the equatorial belt, and in Africa, the DR Congo, Central African Republic, going to the Congo Brazzaville and passing right across to the Amazonian areas. These are the areas where onchocerciasis is most impactful. It is an age problem. In fact, in some areas in DR Congo, it causes a lot of blindness. You can have so many people in a village who are blind, and this is because of an inflammatory process affecting especially the cornea in these patients. 99% of the infected people live in Africa, and especially 31 countries of Africa. But what has emerged is that the higher the community infection prevalence by Onchocerca volvulus, the higher the prevalence of epilepsy. So much so that in one study, Payon et al. Conducted a meta-analysis of all the studies which examined the relationship between epilepsy and Onchocerca volvulus, and demonstrated that for each 10% increase in the prevalence of Onchocerca volvulus in a community, there is a 0.4% increase in the community in the prevalence of epilepsy. And now, and this was actually even demonstrated elegantly in a study in Cameroon, where using the distance from a river bank, because this disease is transmitted, the parasites are transmitted by a Similian fly, and the fly lays its larva in fast-flowing rivers, which have a very high concentration of oxygen. And the longer the distance from the river banks, actually the lower the more the decline in the prevalence of epilepsy. The further you are away from the river banks, the less the risk of epilepsy in some of those regions. There are currently quite a number of studies which are now working to understand the pathogenesis of how this disease, which this parasite, which is usually in the skin or in the blood, and which is usually not found in the brain, how it causes epilepsy. But in the last few years, I've also spent quite some time looking at this strange disease, which has been described in southern Tanzania, initially towards the Zambia border, but also in South Sudan and in northern Uganda. And it is characterized by atonic seizures and myoclonic seizures, especially a unique form of epilepsy characterized by repeated head nods, and then a progressive deterioration of neurological function, cognition, motor abnormalities, and neurodisability. The disease affects mostly children between the ages of 3 and 8 years. That is the peak incidence when it starts. You have increasing inattention in these children, dizziness, lethargy, and several weeks later, these children then develop repeated head nodding. And a year to 3 years later, then they develop different forms of epilepsy. Tonics, atypical absences. Most of them may be focal seizures, myoclonic seizures, tonic-clonic seizures, and progressively they then develop motor and cognitive deficits with severe cognitive decline, behavioral and psychiatric abnormalities, and quite a number of them. For example, there's this image of 3 brothers. This extremely short boy is a sibling of these brothers. He was when we took this picture, he was a 13-year-old, but his height was that of a 5-year-old. So some of them are really severely stunted. It affects growth, and from some of the initial studies, what we found out was that it affects the insulin-like growth factor. So translation of growth, it becomes a problem. There are a range of psychiatric malformations, but very severe epilepsy. Consistently, again, this disease has been associated with Onchocerca volvulus, but the questions of why it is in localized areas, not across all the different regions, still needs to be determined. But we're conducting several studies, pathogenesis studies, to try to understand it. And one current studies suggest that there may be a cross reaction, an immune reaction of the host immune response cross-reacting with the host immune response against Onchocerca volvulus cross-reacting with human proteins, especially those involved in epileptogenesis. And several of these studies, hopefully by close of next year, will be able to share final data which have examined this in detail. But because of this association, for example, in Uganda, we caused a widespread government-mediated intervention to try to control this disease. And just by attempting to control this disease, applying larvicides in the rivers and giving ivermectin twice a year so that it kills the microfilariae which are produced by these worms, we have in the last 5 years not had a single new case of the nodding syndrome. So we only have the prevalent cases which are continuing. The other disease which causes a lot of trouble in Africa, trypanosomiasis, we have 2 forms, the West African form and the Rhodesian form. And so Trypanosoma brucei-gambiense, which is for the West African form, and then which is usually found in West and Central African and up to northern parts of Uganda. And then Trypanosoma brucei-rhodesiense, which is from the southern parts of Uganda going to South Africa. This disease, this is one of the One Health problems. And so with good interventions, control measures at the community level, it can be addressed. Otherwise, where control in areas where wars come, often it comes back. So long as there is peace and the interventions, the veterinary services and the human health services working appropriately, this disease often gets controlled fairly well. I want to to end by talking about HIV, because this is the other problem which causes a lot of the brain diseases and epilepsy, in acquired epilepsy, which we see in our region. HIV infection of the brain actually occurs fairly early. Although the brain is a protected area, the virus manages to cross the blood-brain barrier, and this is mediated actually through the infected macrophages or the microglia, using a Trojan kind of activity trajectory through, and this is CD4 dependent. And then this is further facilitated, and especially the injury is facilitated later on by the infected astrocytes in the brain, which cause death of the neighboring astrocytes, but also causing neuronal injury. So much so that in young children, the brain growth is compromised, and the children are microcephalic, as opposed to adults where the maturity is achieved. The symptoms in HIV infected individuals where there is CNS disease, they may be cognitive, where patients start forgetting things, developing confusion or dementia, lots of focal weakness, and many of the focal weakness may be due to opportunistic infections or others, changes in behavior, headaches. Again, you may have opportunistic infections like the toxoplasmosis, which we have described, and of course, seizures, the topic of our discussion today, impairment in balance and coordination, changes in vision, and the focal neurological signs which develop, difficulty in swallowing, and then in disorders of sensation and mental health. Now, seizures in HIV-infected individuals can both be acute, or they may be as part of the progression of the disease, or they may be due to the opportunistic infections, or they may be related to the therapy, the drugs which the individuals are using. So we may have HIV, mass lesions, focal lesions, viral encephalitis, meningitis, and especially meningitis from TB, but also in those who are severely immune compromised, even pneumococcal meningitis. Many of them may develop stroke and metabolic disorders. So the range of and the causes of seizures in HIV-infected individuals is wide. And because of this, a more careful history and examination is required. Now, many of the HIV-infected individuals are on protease inhibitors. And because of that, many of the anti-epileptic drugs which we have available, carbamazepine, phenytoin, and phenobarbital, many of them are enzyme inducers. So much so that if they are given to some of these patients who are on antiretroviral therapies, you may lower the efficacy of the antiretrovirals, so much that paradoxically, you may worsen the HIV disease, the viral load may grow up. And because of this, the ILAE constituted a team, which team examined these questions carefully and proposed that in individuals who may be HIV infected, the drug of choice, the anti-epileptic drug of choice should be sodium valproate. Although there's a degree of enzyme induction, it is much less in many of these regions. So as a first-line medication, sodium valproate may be the drug to use. I already mentioned that in infants, they may have the severe developmental delay and encephalopathy, and especially those who are perinatally infected. And many of these children have subtle neurological signs with spasticity, hyperreflexia, and this is really the classical HIV encephalopathy. And some of these children may present with seizure disorders. The problem is the co-infection, HIV and TB. And because of this, the anti-tuberculous drugs may compromise the antiretroviral drugs, and they may compromise also the anti-epileptic drugs. So managing this group of patients is one of the most difficult. But of them, TB kills you much more quickly. So often the intensive phase of TB treatment is therefore focused on first, and then they take off and they start making emphasis on the treatment of HIV during the continuation phase of TB, and using again sodium valproate as the drug. But where you may substitute the protease inhibitors with other drugs, then one can use the other drugs, including carbamazepine and the rest. I want to end with these conclusions. Across Africa, we have very many easily preventable parasitic infections, but these infections are a major cause of neurological and mental health disorders and epilepsy. And many of these parasitic infections are helminthic disorders, which can really be treated with very simple drugs, but they may be, their importance may be local, and especially in the older child, the adolescent, and the adult. And so in outpatient clinics and in endemic areas, we should include their assessment in the investigation of such patients. Preventive public health measures against such parasites may reduce the burden of epilepsy. And our thought is that with the decline in the malaria burden and onchocerciasis burdens in the region, we should be able to start seeing a reduction in the burden of epilepsy. But our diagnostic abilities should improve and should consider these specific diseases. Thank you very much.
Thank you very much, Richard, for this very nice and informative and detailed lecture, really. Now we will shift to questions, and we see if any other questions from the audience. I don't know that there is. Well, this subject, is very important, really, in epilepsy, because epilepsy is not only no more seizures alone. It is seizures and comorbidity, and comorbidity really is now enter even in the framework of classification of seizures. Epilepsy is easy when it is only seizures and can be managed in not in a difficult way, but once comorbidities supervene, then we will be in need for epileptologist in such situations. Well, I just want you to speak something really about the nodding syndrome. It is, I think, it's a new thing for us. We heard about the benign nodding syndrome of a baby, but this nodding syndrome and this presentation as an encephalopathy or as a degenerative disease, possibly presenting in parts of its picture as seizures.
Yes, let me see whether I can get something to share. I'd wanted to pick a quick video. It will take a bit of time. The descriptions of nodding syndrome initially started were made in southern Tanzania in the 1960s, and there was an Austrian neurologist who recognized some children who had a unique type of epilepsy, and they came with repeated head nods, and she wondered what the cause of this are. But in the late 90s, there were reports of a lot of such cases, especially in South Sudan. And then shortly, a few years later, in the northern parts of Uganda. Now, all these regions are separate. They are hundreds of miles apart. So it is not the continuation of the same region. And we have been able to study these children in quite some detail. And it is definitely a very severe epilepsy. The children have severe brain injuries. The brains are quite atrophic, with very large ventricular spaces. Over time, many of them die, but most of those who have died out of status epilepticus. So it is not usually the disease which kills, or many of them just get uncontrolled seizures and they have died out of it. But when we started the interventions, in Uganda, we have been giving them sodium valproate. Really, we have many of them have improved. Within the first year, up to a quarter of them were seizure-free with sodium valproate. The progression in many of these children was arrested. So there is an element of epileptic encephalopathy. So on the EEGs, in a number of them, you see really continuous discharges, and worse at night, like so SS. It also is demonstrable in them. So my feeling is that both the disease and the epileptic encephalopathy contribute to the deterioration of the patients. And so where we were able to terminate, to give adequate anti-epileptic therapies, the response has not been very well on the other drugs like Phenytoin or Phenobab. But once they were started on sodium valproate, from our studies, they have really done, the majority of them have done well. But we have not been able to wean off anybody from the drugs. When you stop it, the seizures come back. So it's really a symptomatic epilepsy. They're on it. Most of the patients in Uganda have now grown, late teenagers and all early 20-something-year-olds. We now have no young children. And for the past 6 or so years, we have not had a single new case. So we have over 2,000, but with the disease, and in most of them, the disease is arrested. They are a group who have severe disability. They have remained there. Then the others who now are ambulant and able to perform their own tasks, take care of themselves. Some have gotten married. They are living with it. So there's both some good news and bad news. But in general, I think probably if the etiology is Onchocerca volvulus, which I think it is, it may be in addition to some other agent. Maybe there is an additional agent, whether it does not look to be from a genetic background. We have done a lot of genetic studies and we have not been able to identify any relationship with any non-epilepsy gene. And we have also looked at a lot of toxins in the area. We have not been able to identify any unique one, but there may be a cofactor. Which cofactor is what we have not identified.
Mm-hmm. Well, a question from Dr. Nibal. What is the duration of treatment of seizures that are developed during acute CNS infection, bacterial, viral, or due to other pathogens? Is it related to the time of occurrence, severity of or EEG manifestations?
Different centers do different things. So acute seizures, if it's a single seizure also, it is terminated. Often people do not have a continuation of anti-epileptic drugs. Those who had protracted status epilepticus during the treatment, for example, the ones of cerebral malaria, once it's terminated, often they give somewhere 2 or so days But those who remain in coma and are required for the next 2 to 3 days and they're still having seizures, often they can then maintain the anti-epileptic drugs for another 2 weeks. So in the majority, it's rare for individuals to go to 6 weeks of anti-epileptic drugs. The majority of them are just a few days to about two weeks after the acute episode, and that is what we do in our centers. We usually do not have long periods of anti-epileptic drugs. The different thing is after they are discharged, the acute episode is treated, and then they develop epilepsy. Now that is different. Then then you follow the guidelines of treatment of epilepsy until seizure freedom, the epidemiological ones, which individuals use, of whether 1 to 2 years of seizure free before you're able to take up the anti-epileptic drugs. So for example, the children with cerebral malaria who develop epilepsy 2 years after, then we treat and we consider the usual guidelines, principles of management of epilepsy.
Thank you very much. I want to Dr. Richard, to excuse me to ask a few questions to Dr. Hassan, because some colleagues sent questions, so can make a compromise between you both.
Yes, please.
One question is, Dr. Hassan, that if the patient had a severe TBI, traumatic brain injury, without seizure but high risk to develop seizure, should we treat the patient in short time to prevent brain injury? Your voice is not heard. You mute yourself, Doctor. Yes.
Yeah. Okay. In fact, as I mentioned, 50% of patients with a severe TBI that may develop epilepsy. But still, we had discussed that in the beginning, and after I finished this lecture, you cannot give a prophylactic treatment for a patient until there is a proof. If there isn't any proof of epilepsy, you just stick to the first week treatment with anti-epileptic drugs, injectable agents like Phenytoin previously, and now we are using levetiracetam as it is less toxic. But I mean, if a patient went out from the hospital and he had no epilepsy, or let's say no fits after that, we don't usually give prophylactic management. But if a patient comes back with the focal or generalized seizure, then we have to perform an EEG. And then from the EEG, if there is a clear focal discharge, then we have to start antiepileptic medication. And it's just like with the questions about meningitis and encephalitis, I mean, with the infections. If you have no proof that the patient have real epileptic discharge from a single focus in the brain by an EEG, then you should not use medication as a prophylaxis. I know that some of our colleagues, neurosurgeons, they are using carbamazepine for 6 months. But you cannot, there's no clear, evidence that it would be useful. As I mentioned, there will not change the story of epilepsy or developing PTE in patients with epilepsy. I mean, if you are using carbamazepine for a patient who is not epileptic for 6 months, this won't change the prognosis. I mean, he would develop maybe epilepsy maybe after years. So this is the answer. I mean, no prophylaxis until there is a proof.
Yes. Have you a question to Dr. Richard? I think you, Dr. Hassan, or well, one question.
I mean, I have a comment. I mean, you know, the same as the question of Dr. Nibal. If you have a patient with viral encephalitis that we are encountering in our practice, herpes encephalitis, and here is the situation is a little bit different. I mean, patients usually develop fits during the acute phase of illness. And I would believe that we need to use prophylactic management for those patients. I think it's mentioned in our books that patient with herpes encephalitis should have a prophylactic management for 6 months maybe. And the question or the comment for Dr. Richard to speak about that. For herpes simplex encephalitis.
Yes, for herpes simplex, the risk of epilepsy is actually much higher. So in a number of the centers we have, especially down in Eastern Africa, people give at least up to 6 weeks of anti-epileptic prophylaxis, at a minimum of 6 weeks. Some go longer.
Thank you.
Well, Dr. Richard, I have a question really in your practice or in your region about the vaccine and epilepsy, vaccine and seizures. We encountered usually literature always say that there is no relation between vaccines and development of epilepsy and seizure, etc. And we usually we are teaching students in that way, but we encounter in our daily life that seizures may develop after vaccines. And this seizure may be repeated again and again, and the patient may one day go or maybe diagnosed as epileptic. I mean, if in your practice or in your region, there's some comorbidity between the vaccine and epilepsy?
Now, one of our challenges is that we have such a huge burden of infectious diseases and a lot of seizures that it is very difficult to tease and say whether this is coming from vaccines or not. So that one is very rare, partly because of the burden of the number of seizures. So if you are in an emergency unit in a day, you just see so many children coming with seizure disorders, acute seizures, mostly because of an infectious origin. So it becomes very difficult for you to try to tease and say this is vaccine related, this is not vaccine related. That because of that, we find it difficult to go in that direction.
Yes, you are right. Dr. Hassan, a question: how long Phenytoin should be given after acute traumatic brain injury to prevent symptomatic epilepsy? I don't know what he means by symptomatic epilepsy here. In this respect, symptomatic epilepsy, you mean evoked seizures possibly?
Well, again, it's the same answer. It's for 7 days only. And you should not go on for more than that until there is an evidence of real non-provoked seizure. I mean, later on, the patient come back again with a seizure, you need to do an EEG, and then if there is any proof, then you have to use not Phenytoin. I mean, you have to go for carbamazepine, it's better, or sodium valproate.
Well, thank you. Thank you very much. I think this is the end, Dr. Richard. Thank you very much for your nice lecture and your nice answers. Thank you again, Dr. Hassan. And we will meet, definitely, we meet you monthly. New thing is that our webinars in the next months will be a single lecturer, but with full time, 1 hour for a lecture and say half an hour for discussion, and to make such a case of a round rather than a webinar starting from January in next year for both, I mean, still conjoined with the Africa Commission and our Commission. Thank you very much, Dr. Richard, for this nice lecture, and nice to see you here. And thank you, Dr. Hassan, again, and see you soon in next webinars. Thank you very much.
Thank you very much. Pleasure, and thank you for organizing.
Thank you very much.